sejahtera untuk kita semua. Kali ini kita bertemu lagi dalam acara kuliah tamu dan dari visiting professor. Saat ini kita mendapat kesempatan untuk berkolaborasi dengan Princess Maxima Centrum dari Utrecht, Belanda. Dan pada periode kali ini kita akan membahas mengenai infeksi pada kanker anak. Good afternoon all participants. Today, Dr. Sarjito General Hospital have collaboration with Princess Maxima Centrum in Utrecht and also the Faculty of Medicine, Public Health and Nursing Universitas Gadjah Mada. We will present to you the guest lecture and visiting professor to 2022 with title The Contribution of Infection Control to the Outcomes of Childhood Cancers. Here we have 3 panelists already. The first one will be Dr. Bambang Ardianto, PhD, MSc, spesialis anak konsultan. Saat ini beliau menjabat sebagai Kepala Divisi Hematologi Onkologi Anak, RSUP Dr. Sarjito, FKKMK UGM. Kemudian di sebelahnya ada Dr. Judith Speakerman dari Pediatric Fellowship of Pediatric Oncology Princess Maxima Centrum. Dan kemudian tamu profesor kita kali ini, Profesor Gertjan J.L. Kaspers, MD PhD, Pediatric Consultant dari Princess Maxima Centrum. Untuk kesempatan pertama dan kemudian untuk memoderatori acara hari ini, kami persilahkan Dr. Bambang Ardianto untuk memulai sesi ilmiah.
Thank you very much, Dr. Alexandra. Good afternoon, all participants. We are now entering the scientific session. But before we start the presentation from our guest from the Netherlands, let me start with the introduction about the importance of infection control in the management of childhood cancers. As we know that Dr. Sarjito General Hospital is one of the pediatric oncology centers in Yogyakarta Special Territory and Central Java. The average annual growth of our patients was 8.8% based on the registry between the period of 2016 to 2021. Interestingly, the number of growth exceeds the average annual population growth in this area, which is 0.5 to 1.2%. These findings has a number of meanings. For example, there is a challenge that there was increasing number of patients referred to our centers, maybe with the advanced stage of cancers, and then which may lead to more aggressive treatment with the consequence of a high risk of adverse events. And then if we are looking by the diagnosis, most of our patients, around 60%, are children with curable cancers, namely retinoblastoma, Wilms tumor, Hodgkin lymphoma, Burkitt lymphoma, and importantly, acute lymphoblastic leukemia. The consequence of these curable cancers is that it is expected that more than 60% of these patients have the survival rate of more than 60% by the year of 2030. And how about the outcomes? The outcomes of acute lymphoblastic leukemia, the disease with very prevalent in Indonesia, is less than 60%. Our registry showed that cases experiencing no event in the end of treatment only reach 45%. So it is less than 60% as stated by the WHO Cure initiative. And then if we are looking on the causes of death in childhood cancers, most of the death in our patients was due to infections, almost 40%. And the form of infection may be in severe sepsis, pneumonia, varicella, and febrile neutropenia. Our analysis in the year of 2020 shows that more than 10% of patients admitted each month suffering from febrile neutropenia. We didn't have the analysis for the year of 2021 because of the pandemic. There may be more number of patients admitted febrile neutropenia at that year. One of the proposed improvement for getting 60% survival is improving supportive care capacity, including infection control. And now we are inviting Professor Hetjan Kaspers and Dr. Judith Stekerman for presenting about infection in cancers. Thank you.
Yes, good afternoon. It's a pleasure to be in this meeting and to give another lecture. We gave it a few days ago as well. It actually will be a combination of, that's interesting, my mouse is not staying where it wants to. Can you turn on the presentation? Okay. It's the, yeah, thank you. I will start with sort of an introduction to oncologic emergencies, including infections. And then Dr. Judith Spijkerman will take over with much more details on infections and its prevention and its treatment. I'm affiliated both to Princess Maxima Center and to Amsterdam University Medical Centers as a professor. So the objectives of my presentation, I want you all to be aware of the occurrence of oncological emergencies, to know a little bit on the type of emergencies, the possibilities to avoid or to treat certain emergencies, and to make you aware that it really can contribute to improved outcome. So mortality in childhood cancer, well, the first weeks are most riskful in our experience, and even in high-income countries, it can be as high as 10%. And certainly it will be higher in setting with less resources. And this early mortality is mainly due to oncological emergencies. So you can really cure more children with cancer if you have an appropriate management of these emergencies. And it's not only in the first weeks, it's also later on, because if you look at the definition of emergencies, it's an acute, potentially life-threatening or disabling situation that can be directly related to the malignancy or its treatment. And therefore, it may be the initial manifestation of the cancer or occur anywhere during therapy, also even after therapy, as a result of treatment, progression, or relapse. And one of the very important messages here is that this situation may require immediate empiric anti-cancer treatment. Empiric meaning you don't have a full diagnosis yet. You have a working diagnosis, and based on that, you start anti-cancer treatment. And I think I'm understanding now that in your sort of context, it's more complicated perhaps to start treatment without having approval from either the hospital management or insurance company. But I would suggest that you, despite improvements, you do it because it saves lives. And that's what we are supposed to do. So I will talk a little bit on hyperleukocytosis, and some of this is not new for some of you, but perhaps is new for others. I will talk on tumor lysis syndrome, bleeding, and mediastinal mass, and then we move to Dr. Judith. There's many emergencies that I cannot talk about because of time limitations. But for instance, raised intracranial pressure and spinal cord obstruction are certainly very important situations as well. But also masses in the throat and neutropenic enterocolitis. But there's not enough time now. So hyperleukocytosis, well, of course, that is quite typical for leukemia. It could be also present in some other diseases, such as severe infections. But let's now focus on leukemia causing hyperleukocytosis. And it's not only sludging that is a complication of hyperleukocytosis. So let's say thickening of the blood, but also you have a higher risk of severe anemia and thrombopenia. You have a higher risk of diffuse intravascular coagulation, together with the thrombopenia leading to a higher risk of bleeding. You may get biochemical disturbances, even spontaneous tumor lysis syndrome. So without treatment already starting, that you have tumor lysis syndrome. And of course, there's also a higher risk of treatment-induced tumor lysis syndrome. How can you treat hyperleukocytosis? Well, first of all, give hyperhydration, because that dilutes simply the blood, and the leukocyte count usually goes down. Of course, it's important not only to achieve hyperhydration, but also to achieve polyuria. So the urinary output should become high, especially when you start treating the children. All the degradation products must be in the urine that is leaving the body in that way. If you don't have resburicase, you should start allopurinol. I will come back to that, but ideally you give resburicase, and that is mainly to prevent tumor lysis syndrome. There's not much literature on the benefit of partial exchange transfusion. You might take blood and give of the patient and give normal blood back. So in a way that is also diluting the blood and leading to lower leukocyte counts. But of course, it has no effect on the cause of this, being the leukemia. I think we now do not recommend leukocytophoresis anymore in general. There's literature, it does not help. And at the same time, it takes time, it's time consuming, it's cumbersome, it's costly, and it can delay other measures. So, of course, appropriate supportive care otherwise, for instance, antibiotics in case of fever. But what is most important, and another take-home message, start anti-leukemic treatment. So if you have a working diagnosis, either you give steroids, or if you think it's mild leukemia, you either give lower dose of cytarabine or etoposide. But simply start that. Tumor lysis syndrome. So tumor lysis syndrome, well, that is a severe type of tumor lysis. Tumor lysis is what we all want. You want the tumor cells to disappear. But we don't want a tumor lysis syndrome. And that can, as I said, be even spontaneous, but more typical is treatment-induced. And which type of diseases are prone to develop tumor lysis syndrome? That's especially the Burkitt lymphomas, the lymphoblastic lymphomas, and ALL. It's less frequent in AML, although it has been described, and it's quite rare in other types of cancer. So it's mainly the leukemias and the leukemia-like lymphomas. It's characterized by biochemical disturbances and renal failure. Are the hallmarks of tumor lysis syndrome. And there's definitions of these biochemical disturbances caused by the rapid breakdown of the tumor cells, the leukemic cells, or the lymphoma cells. So you get a high uric acid, you get a high potassium, you get a high phosphate, and secondary to the high phosphate, you get a low calcium, because you get precipitation of the calcium phosphate crystals in the kidneys. So there's definitions by Bishop et al. And others have written on it. When you talk about tumor lysis syndrome based on the laboratory values. And this is a table you can find in the literature. It is also mentioned here. It is fine to distribute this talk to the ones that are in the audience. But these are sort of the values above that or below that for calcium. You can talk about tumor lysis syndrome. What are symptoms? Well, that is in a way complicated because they are aspecific, I would say. But nausea and vomiting, shortness of breath, irregular heartbeats, clouding of the urine, lethargy, and joint discomfort or muscle cramps. The latter perhaps is more sort of remarkable and should make you think about these electrolyte disturbances. So the main complication is acute renal failure, and that's actually what we do see in our patients. We very rarely see, I never saw it, cardiac dysrhythmias because of the disturbances in the potassium and the calcium. You may get tetany, that perhaps you know better from women before labor because of a low calcium, seizures, and sudden death. So what is the treatment? Well, the best treatment, as always, is to prevent it. So give hyperhydration, monitor the urinary output, because that's what you need. Look at the body weight. I think a body weight is a relatively easy measure for the fluid balance, which often is difficult. Look at the body weight, at least daily. Look at electrolytes, at least one daily, if it's possible, twice daily or even more frequently. Do look at the renal function by looking at creatinine. If you have a high leukocyte count, you don't want the hematocrit or the hemoglobin to be too high, because then you increase the sludging. So we are always reluctant to give red blood cells in patients with a high white blood cell count. So monitor the white blood cell count. And some look at LDH. I'm personally not so interested in LDH. But of course, it's one of the markers indicating tumor lysis. But you will not get clinical problems from a high LDH. Like I said, allopurinol at least should be given, but ideally in the high-risk patients, you give rasburicase. But if you don't have it, give allopurinol. Give hyperhydration. And once you have tumor lysis syndrome, apart from dialysis, we increase the allopurinol dose. If we give allopurinol, we increase hyperhydration to make an even higher urinary output. We try to correct biochemical disturbances, maintain urinary output, sometimes with drugs such as furosemide. And of course, we start, like I said in the beginning, anti-tumor treatment. And there's a little bit of a debate whether that should be dose adjusted, whether you should start with lower doses. I've been learned by my sort of mentor that you either get tumor lysis syndrome or you don't, whatever dose you give of either a glucocorticoid or cytarabine or etoposide. And I think in AML now, we do give the full dose of treatment. You can start with lower doses, but then don't forget to increase the doses in the next few days. Otherwise, you are not treating the leukemia or the lymphoma appropriately. To remind you about allopurinol versus rasburicase. So allopurinol, that works by inhibiting an enzyme. The name is xanthine oxidase. And that takes a while. And then the xanthine oxidase normally converts hypoxanthine through xanthine to uric acid. If you inhibit that, you get less uric acid. But that takes a while. So it takes at least 24 hours. So it has no immediate effect. And the biggest advantage of the rasburicase is that it has a direct effect on degradation of uric acid, converting it to allantoin. So that is why we prefer rasburicase, because it has an immediate, fast, strong effect. A few words on bleeding. Obviously, often caused by low platelets, especially when you combine it with invasive procedures or a child falling from the stairs or whatever, having an injury. It can be worsened by diffuse intravascular coagulation. How to look for that, and in which diseases will we see this diffuse intravascular coagulation? Well, looking in the lab, we look at clotting times, typically APTT and PT. We look at the fibrinogen, which is then lowered, and we look at dimers, which are raised if you have DIC. And the very classical disease that causes this is acute promyelocytic leukemia, but it is also seen in other myeloid leukemias, especially the monoblastic leukemia, and it can be seen in other types of acute leukemia. So it is good to think about this because you can treat it. Of course, for the low platelet count, you give platelets, but when you have DIC, you can give free frozen plasma or fibrinogen, and even sometimes, but that is very expensive, the drug called Novo7, activated factor 7A. Finally, on mediastinal masses, and well, when to suspect it, how to diagnose it. And I think this is a guy from Indonesia. And normally when we would have time, I would have spent more time on what is wrong, what do you see? I think I'm seeing him sitting upright. He's puffy. You might think there's some swelling here, apart from he's being obese. You cannot see from the picture, but he is short of breath. And if you look at the chest X-ray, you see a widened mediastinum. And you might agree with me that here there's compression on the higher upper airway. So the mediastinum, There are 3 compartments, and typically the anterior and superior part are taken together, superior anterior part, and you have the middle and you have the posterior mediastinum. And if you look at the chest X-ray from the side, this is anterior, this is in the middle, and here it's more posterior. And this is another way of looking at it, more or less the same with the superior here. What perhaps for us is more important is which structures are in there. And in the middle, certainly, of course, the heart, the main bronchi, but the lymph nodes in the anterior, also lymph nodes and the thymus. While in the posterior mediastinum, behind the pericardium, there is the sympathetic cord. And of course, the esophagus and the aorta. So with this in mind, you understand that when there's a mass in the anterior mediastinum or anterior plus middle, and sometimes superior, it's often lymphoma or a leukemia with lymphoma involvement. It could be, however, a teratoma or a thymoma, and sometimes, rarely in our setting, perhaps more frequent for you, an infection, such as tuberculosis. In the posterior mediastinum, however, it's very rarely these diseases, but it can be a neuroblastoma or a germ cell tumor or sarcomas, such as an extra-osseal Ewing sarcoma. And the problem of these masses is that they may compress the upper airways and they may compress the vena cava superior. And especially compression of the upper airways is really serious and potentially life-threatening. And because these cancers in these children are fast growing, it really may be very rapidly progressive. So you have to be fast when you detect this. So realize that this may happen, diagnose it, and then treat instantly. And that really saves lives. Symptoms, again, it can be quite aspecific, right? A dry cough, being hoarse, some orthopnea, pain on the chest, anxiety, and of course, signs of vena cava superior syndrome. But also sometimes there's hardly any sign or symptom. So what is the danger? It's not only direct obstruction of the upper airways, but also when you need to intubate, it may be impossible. When you lie down, like in a transport in the ambulance or for imaging, it may worsen. And when you do sedation for a puncture of the bone marrow, for instance, you may worsen this. So avoid anesthesia in these children. And avoid lying down anyway, because sitting upright gives better oxygenation. It increases the vital lung capacity, decreases the chance of developing atelectasis, and you have a better VQ, ventilation perfusion matching. What we do is we take bloods in these patients. We do a chest X-ray. We do it routinely in leukemia and lymphomas. If we do a CT scan, if possible, we do it upright. Otherwise, be careful. We do an echocardiogram, if possible, upright. We assess carefully the risk of anesthesia. And in doubt, we avoid it. And the diagnosis should be done in the least invasive measure. So this is not for now, but this is a flow diagram that you can use to make decisions on biopsying or not, and to give empiric treatment or not. Again, please, as a take-home message, you may every now and then need to start treatment without having a final diagnosis. So the high-risk patients, they will need it, and mostly we give steroids, sometimes an anthracycline or the combination. And then you delay getting the diagnostic material, but that's okay if it's a couple of days. We can even have biopsies after 5 or even 7 days and still get informative biopsies. So it's more important to save lives than to get immediately a biopsy. Well, this certainly is too detailed to discuss, but it helps you through the differential diagnosis and what the approach should be. So this is more for looking at it carefully at home. Before I move to Dr. Judith, my take-home messages: awareness and recognition of oncological emergencies is really essential. If you recognize it and if you immediately, appropriately handle, you save lives. That means you may need to give empiric anti-cancer treatment. And in case of tumor lysis syndrome, make sure there's hyperhydration, make also sure there's high urinary output, give allopurinol, and if you have, replace it by resburicase, and check for the electrolytes. And I guess I should also say the renal function. Thank you so much. I guess we have questions after Dr. Judith, and I give the mouse to her.
I would like to talk to you about infections in pediatric oncology patients. My name is Judith Spijkerman. I'm an MD PhD and currently working nearly in my third year of the fellowship in the Pediatric Oncology Center in the Prinses Maxima Center in Utrecht in the Netherlands. And I would like to talk more about viral neutropenia, also about bacterial infections, viral infections, the pneumocystis jirovecii pneumonia, which I will later call PEP, and also about invasive fungal diseases. But I have to make a disclaimer because, of course, I am not an infectiologist. And second, I can tell you about our experience. So that's Western European experience, and I can, of course, give some data regarding literature that has been available. But unfortunately, that's mostly about the Western population. So I'm very much interested in discussing afterwards how we can apply these results to the Indonesian situation. So in general, on the right side, there you see our mortality curves. And it was only 50 years ago that we had a mortality rate of 80%. So only 20% of the children survived. So in 50 years time, we now increased until 80%. And that you can also see here when you combine all pediatric oncology diagnoses, that 80% of the children survive after 5 years. So that means 20% of them died. And if you look, that's big amount of that is due to progressive disease, but also part is due to treatment-related mortality. And particularly in the hematological malignancies, you see that more people die of treatment-related mortality, more children, than due to progressive disease. So that's our new challenge. And if you further subdivide the numbers that actually died due to treatment-related mortality, then nearly half of the patients died because of an infection. So not only in Indonesia, but also for us, infections are really important to manage. So in the basis, why do infections play a major role? That is because we, during treatment, we disrupt barriers. So not only due to mucositis, but also because we are used having central venous lines over which we give the chemotherapy. But also we know that all the medications influence all the different aspects of the immune system. With the most important one for infections for us would be the neutrophilic granulocytes. If those can become low and less of function due to chemotherapy, and that of course is a known risk factor for bacterial and fungal infections as well. So next to the innate immune system, of course, we also know that all the medications do have influence on the adaptive immune system, so the T cells and the B cells, and those give, of course, different diseases. From very early literature, that's already been known that when you have a neutropenia below 0.5, that it firmly increases the risk of infection in leukemic patients. So that's the definition we are now used to when we talk to parents about the risk of infections. We know that after intensive chemotherapy, usually 10 days after, children are what we call in neutropenia. So they have neutrophil granulocytes below 0.5. And we always instruct parents to phone us when they have noticed that their child has had a fever, at least of 38.5 degrees, or repeatedly above 38 degrees. And then we discuss with them where should the child be seen, and that we call that the golden hour. So it should be seen somewhere close nearby, if it's possible within 1 hour, so that a physician can actually check the child, also look for symptoms of sepsis, take a blood culture and start antibiotic treatment as early as possible on an empirical basis. We know that from all these children, we can identify an infection, a clinical infection in 10% of the cases. So it could be a pneumonia, for example. And in 30% of all the cases, we could define an infection based on microbiological results, of which 2/3 would be a bloodstream infection. But in the other 60%, we cannot affirm an infection. However, that could be due to less sensitivity of a blood culture, but it could also, you have to also always think broad, be an other cause of fever in these children. So for example, mucositis, of course, induces fever, or cancer fever, drug fever, transfusions reactions, and autonomic dysregulation for children with brain tumors. So how do we treat fibroneutropenia in our setting? Of course, that could be different between settings because that depends on local resistance and clinical presentation. We would use as a first choice ceftazidime. So that's a 3rd generation cephalosporin. And in the Netherlands, it still covers almost all isolates of Pseudomonas, which is an important bacteria to cover because it's known for a higher mortality. So with the ceftazidime, you attack most gram-negative bacteria. But we would add a gram-positive antibiotics as well. So in our setting, it would be vancomycin to cover for bacteria that are known to present with sepsis, for example, the aureus or the mites. We would add vancomycin if a child received high-dose RSA, so after AML treatment, or the child has symptoms of mucositis. So you can think of the gram-positive colonization in the mouth area that can be invasive. Or we have clinical symptoms suggesting that there is actually a central venous line infection. We would think about adding flagyl, so metronidazole for children that present with clinics of neutropenic enterocolitis, so to cover for anaerobes. And only we would start, instead of ceftazidime, first with meronem, when we know that the child has a colonization with either Citrobacter or Acinetobacter or Stereotrophomonas. So those are bacteria that are known to become resistant when you treat it with cephalosporins. However, what we do is actually not what has been recently published by the ASIL guidelines in the Lancet Oncology paper, so in 2021. And that's, of course, the whole European setting, and it's only for leukemic patients, but those are, of course, at high risk. And for stem cell transplantation patients. And what they make a difference, so they say if you have a stable child not presenting with a sepsis, your first choice would be a 4th generation of cephalosporin to be able to cover more isolates of Pseudomonas, because in a lot of other countries they have more resistance problems. They say if the child has a sepsis, you should directly go to carbapenem, and also think about adding maybe another anti-gram-negative agent like gentamicin, or think about adding vancomycin to carbapenem. We would not usually do that because you would only add coverage for an enterococ or a staphylococcus. How do you say that? CNS? Staphylococcus negative Coagulase and negative Staphylococcus, and those pathogens are usually at low risk for clinical symptoms. So we would wait for bacterial culture results and then add vancomycin in a second stage. This illustrates that your antibiotic treatment has to be adapted to your own colonization patterns. So how do we do the de-escalation of antibiotics? So of course, we treat too many children, whereas not every one of them does have a bacterial bloodstream infection, as we know. So of course, when we have found a pathogen, we have to adapt for that. And that's, it's a Dutch written words, but here you see that usually when there's a gram-positive bacterium found, that you have to treat for like around 7 days. And when it's gram-negative, you have to prolong the treatment. And we also have to think about removing the central venous line catheter, because we know for all these bacteria that we cannot actually clear the infection without removing the central venous line catheter. So if we don't have a proven bacteremia, and we had a patient who presented herself without a sepsis, and the patient is actually clinically well and does not have a fever for at least 24 hours, we would think about stopping the antibiotic treatment after 48 to 72 hours. In contrast, if the patient presented with a sepsis, we would continue treatment for at least 1 week IV. And we would only consider maybe stopping the gram-positive coverage earlier. So how can we prevent these infections? Because they are important in mortality rates. Besides hand hygiene and social distancing and the dietary restrictions, we give the same dietary restrictions as we would give for a pregnant woman. But how about antibacterial prophylaxis? Currently in the Netherlands, we use ciproxin, and we only use it for high-risk patients, which we defined as having an AML or after stem cell transplantation or having recurrent ALL. And we also use it for neuroblastoma patients in induction treatment. And we recently stopped using ciproxin as infection prophylaxis for the regular ALL children. If you look in the literature, there is not really much good studies performed on this subject. And the biggest study for the highest risk patients, so those are the AML, relapsed ALL, and the stem cell transplantation patients, was performed by Alexander et al. And was published in the JAMA. And they had around 600 children that got either no prophylaxis or levofloxacin prophylaxis. And they demonstrated that the risk of having a bloodstream infection is significantly reduced for the children who have an AML or a relapsed ALL. However, they could not demonstrate significance in the children who were after stem cell transplantation. They did also further secondary analysis on mortality, and they demonstrated that there was no significant effect on mortality in this study. But of course, it's 600 patients, so it's not really large. But there are some limitations that you can think about when looking at these data, because this is the largest and it's the randomized study, so it's really good quality, but still, they only follow children for 2 chemo courses or only during the stem cell transplantation. So it's a short follow-up, and the question will be, what will happen if you continue and prolong the prophylaxis? How will that influence resistant patterns and maybe induce a more difficult to treat bloodstream infections? Also, they did look at the impact of having antibiotic prophylaxis on the incidence of invasive fungal diseases. They did not prove a significant difference. However, they only calculated the risk when there was a proven invasive fungal disease. And we know that's really difficult to prove an invasive fungal disease. So there are really low numbers. And the last thing you could think of is that in this case, in this series, there's quite a high incidence of bloodstream infections. So usually it's higher than we usually see. So that also influences significance. So the question would be, if you have a lower incidence, would it still be significant decline? So about the antibiotic resistance, there recently has been published a big paper by Castañeda et al. And it was a multi-center paper where they investigated all positive bloodstream infection isolates of 13 countries throughout Europe, but also some countries from Southern America. And they checked for resistance. So there were like 1,300 isolates in this study. And you see that there's already quite a lot of resistance. So all different kind of antibiotic treatments, and they did multivariate analysis. So they checked for what are the risk factors, and they discovered that previous antibiotic use, so either as a treatment or as prophylaxis, is in this study a risk factor for having a gram-negative bloodstream infection. And we know that those resistant gram-negative bloodstream infections are more difficult to treat and may have a higher risk of mortality. So this is, the data on the children, but we know also from the adults that using antibiotics induces more resistant strains that can be more difficult to cure in the longer term. So because of these arguments, the most recent paper that has now been published also by the ASO guidelines in 2021 has changed their recommendations regarding the prophylaxis of bacterial infections. So they say that it should not be standardly used in pediatric patients who present with lymphoma or leukemia or a relapse ALL or during stem cell transplantation. And they say that is because there's no decrease in mortality. That is because we see enhancing risk of resistant gram-negative bloodstream infections. And secondary, we know there might be more adverse events. Every medication that you add gives more risk of adverse events. And of course, there's known CYP3A4 interactions with possibly other medications that you give. Then a part about viral infections, the varicella zoster, the herpes zoster. We also see that very frequently, and probably you will see that as well. Yeah, and we know that there are a lot of known complications of these diseases that are actually more frequently seen in immunocompromised patients. And not only complications, but also mortality rates are higher when you are immunocompromised. So it's 1 in 10, that's quite high actually. So that means that when we see a patient who has varicella or herpes zoster, we would directly treat with acyclovir or valacyclovir, depending if you mention this as a disseminated disease or not. So if it's multiple dermatomes or it's multiple organs involved, then it's a disseminated disease. And then we would say you need to be admitted to the hospital to get IV treatment for this. And then you decline the mortality rates to only 0.5%. I'm not sure if you, we have also, when we know that a child is seronegative for the varicella, we would instruct parents when this child develops, has a contact with someone who actually had a varicella, that he should come to the hospital and receive specific immunoglobulins against varicella. That should be given as soon as possible. And we think that that gives a protection of about 2 weeks and the later risk of developing disease. We not frequently give prophylaxis using valacyclovir, actually only for when we use T-cell depleting therapy like fludarabine, or children after stem cell transplantation when they are seropositive, so to prevent reactivations. Then a short part about PEP. That used to be defined as a parasite and now is one of the fungi, but with different risk factors. So I kept this one separately from the other invasive fungi diseases. And of course, it's known, this agent is known due to the HIV-infected patients. But other risk factors, of course, are leukemia, steroids, temozolomide, rituximab, and stem cell transplantation patients. And the symptoms that they have are very aspecific. But if you don't treat it, will progress to severe respiratory failure, particularly more oxygenation than ventilation problems. So if you have that clinic combined with this picture, then you should always think of PEP. So it's bilateral interstitial pneumonitis with more oxygenation and ventilation problems. So the incidence overall in immunocompromised patients that are not HIV infected is known to be around 6.4%. There was a Cochrane review performed in 2014 who demonstrated that. And the treatment should be cotrimoxazole besides prednison. And we know that if you don't treat these patients, that they will probably die. And if you do treat them, they still have a risk of death. So this Cochrane paper demonstrated that it's highly effective that Cotrim is highly effective in preventing PEP. So, and with a low number needed to treat. So you have to treat 19 patients to prevent one case. However, of course, you all know that there are adverse events associated with PEP prophylaxis, like myelosuppression, allergy, interactions with the MTX. So hey, you always have to think about stopping it before you start high dose MTX, or usually we don't give PEP prophylaxis on the MTX days. And in the Netherlands, currently we use PEP prophylaxis for 3 times consecutive a week. And we continue with that until 3 months after treatment. When there are adverse events, we would use pentamidine IV. So the last part is about invasive fungal disease. And it's on the one hand, it's a very important topic, but it gets even more important if you use less dose reduced chemotherapy schedules. So I think it's nice to maybe have a short presentation about this as well, because we know that these microorganisms, I don't know if you can recognize them, it looks really nice and you can make a painting out of it, but we know that they are associated with a really high mortality, particularly this one, it's 50 to 80%. So this is the Aspergillus, a mold, Candida, and those are the most frequent ones. But this one, mucormycosis, we also see it sometimes, a few times a year. This one is associated with a really high mortality. So what are the known risk factors for invasive fungal disease? Of course, the same ones we previously mentioned, but also prolonged neutropenia, high dose steroids, and immunosuppression probably might be due to graft versus host disease that you need to treat, and then you have more risk for invasive fungal diseases. In the Netherlands, we are still using it for children who are being treated for a non-Hodgkin lymphoma or a neuroblastoma, but that's actually not quite the guideline that is recently presented regarding this, also in the Lancet Oncology paper. And we would use as primary prophylaxis itraconazole, but not during induction treatment for ALL, because then we would use micafungin. So for the ALL patients, we would only use it in separate blocks that are known to be associated with high risk of invasive fungal disease. So the induction or the reinduction, or the delayed intensification, we call it, for example. So because there's an interaction with the vincristine, we use micafungin fungine twice weekly IV in these children during induction. So the symptoms are really aspecific. Sometimes only a nasal congestion, but it's usually children who present with febrile neutropenia, but the fever persists after 4 days, and it does not respond to broad spectrum antibiotics. Then we will look further and investigate in high-risk patients what could be the cause of this fever. So for children who also present with the nasal congestions, we would not only make a CT of the thorax, but we would also add a CT of the sinus, because we know that the Aspergillus is an airway pathogen, so it can either usually go down in the lungs, but it might also present only in the sinuses. And we know that children have a less specific CT result. So nodules, tree and bud, halo, infiltrates could all be signs of an invasive fungal disease. So then you need more investigations to actually try to prove what kind of disease you're dealing with. So the way we would do that is not only to do a ball. A ball is the bronchoalveolar lavage. So the fluid in the lungs, we would measure not only for galactomannan as a serum biomarker, or in this case, a lung biomarker, because we know that the galactomannan is more sensitive if you investigate that in the lungs. But we would also try to culture the fungus, but that often does not work, or we would use fungal staining and to do cytology by the pathologist. The biomarker galactomannan in the blood is not known to be really sensitive and specific. We do it though in these kind of patients, also when they don't have a fever yet. But yeah, there's a bit doubt how much earlier we can be in identifying an invasive fungal disease. Also the blood cultures I mentioned here, because in other hospitals in the Netherlands, they usually culture the blood only for 5 days. And when there has been no growth, they would just stop the culture and say, okay, it's negative blood culture. But in our hospital, because they know it's pediatric oncology patients, they would continue culturing until 7 days. Because we know that, for example, the Candida will grow really slow. So you won't find it. You maybe don't find it if you stop the culture at 5 days. So if we, for example, did the CT thorax and we did not find any abnormalities, we would, in high-risk patients, we would perform an ultrasound, abdominal ultrasound, to look for hepatosplenal candidiasis. If we do see these abnormalities, we would not only perform the BAL, but we would also look how to the dissemination of the fungus. So we need to perform an MRI of the brain and of the sinus. And usually we are not able to get a very quick MRI. So we say it's important to start treatment, and we have to make sure to get an MRI as soon as possible. And we would start treatment with a higher dose until we are sure that there is no invasion in the brain. Then we can lower the dose of the ambisoma. So because it's a hard diagnosis, an invasive fungal disease, there has been epidemiological descriptions made. So it's a possible fungal disease. So based on radiological abnormalities, or you can call it a probable invasive fungal disease if you have a positive galactomannan, or a proven fungal disease, as I just mentioned for the Alexander paper. But then you have to have a positive culture, and that's hardly, that's difficult. So what kind of therapeutics do we have currently? Because some are more recently developed, the ecocandines, but of course the azoles and the polyenes we have. And all three groups have different ways of working mechanisms. So the one, for example, the azoles, they influences the synthesis of the membrane. The polyenes influence the function of the membrane, and the ecocandines influence the synthesis of the cell wall. And that induces different kind of adverse events because they're totally different medications. And azoles can be used either IV or orally, so that's really an advantage. But we know that they are associated with severe skin rash, severe liver function problems, and neurotoxicity. So for some patients, not ideal. And the polyanes are known, so like, for example, ambisome, for nephrotoxicity, electrolyte problems, infusion reactions. So sometimes you have to stop that in certain patients. And for the last one, the newer recently developed medications, the ecocandines like micafungin that we also use during induction treatment in ALL patients, are known to be better tolerable. So if you still look at the 3 common groups of invasive fungal diseases, the Aspergillus is known that the azoles are more effective than ambisome to treat. But we know there are resistant strains. You have to have therapeutic drug monitoring in the blood. There are known interactions with vincristine and toxicity. So in our practice, we would start a double therapy with not only voriconazole, but also ambisome, wait for resistant patterns, and then try if the voriconazole is on a good level to stop ambisome, and then follow up with follow-up scans. For the Candida, the first choice is ecocandines. Those are superior to azoles. And however, it's known that ecocandines do not penetrate the brain, so it's not always the best choice. And you need also to think about removal of central lines. The last one is the mucormycosis. That's a really tough fungal disease. We lose children due to this disease. There's a mortality rate of 50 to 80%. It is known that you need to give high dose of amphotericin, and that you have to get the surgeons involved for surgical debulking, and that's also associated with better survival. And only in the second step, we would use azoles when possible. General measures, of course, are when you have an invasive fungal disease, it's a threat for the child. So you have to stop your therapy. You might give Neulasta or Nupogen. You can think about granulocyte transfusions. That's not really hard evidence. In some settings, gelation therapy is being given, but that's not advised based on literature. And hypobaric oxygen is also mentioned, but there's no evidence for that as well. So how long do we need to treat? Actually, until fully recovery of symptoms and the child having no neutropenia anymore. And at least 14 days when you only have a bloodstream infection with a candida, or 6 weeks when there's tissue invasion. And for an Aspergillus or mucor, at least 6 to 12 weeks. So very long. And you have to think about secondary prophylaxis if you want to continue the oncological treatment again. So in summary, infections currently in the European countries are still inducing 50% of the treatments-related mortality. So those infections are bacterial, also viral, but also fungal, as you have shown you. The empirical therapy for febrile neutropenia should be started as soon as possible, but based on local guidelines. The bacterial prophylaxis does not prevent mortality in the West European setting and does enhance resistance. Therefore, it's not advised anymore. PEP prophylaxis is known to be highly effective in risk groups. If a child has persistent fever in neutropenia, search for invasive fungal diseases, because we know it results in a high mortality. And think about primary prophylaxis despite drug toxicity when you have a high-risk patient that you take care of. So I have a lot of questions while making this presentation, because of course it's totally different here in Indonesia. So yeah, what are the challenges here? What are the data regarding infectious complications? Yeah, what kind of infections are that? And how was the treatment and how can we improve? What do we know about resistance, colonizations? And of course, there are different risk factors. Yeah? Dose reduced protocols, no central line, malnutrition. And maybe there's also a need for additional investigations during febrile neutropenia for other diseases. And you're also dependent, of course, on the availability of antibiotics and antifungal treatments, and maybe also other things that could be play a role. So, yeah, I'm not sure if we can discuss it now or maybe in a later phase, but of course, yeah, that's important. So thank you all.
Thank you, Prof. Kaspers and Dr. Judith, for the nice presentation. We are now coming to the discussion. We have one question from the audience. We have a question in the chat box from Dr. Amira. She is a pediatric oncologist from Padang, West Sumatra. Her question is, how can we differentiate between fever due to infection and fever due to malignancy in condition when all cultures you have done are negative? Maybe Dr. Judith can address to her question.
Yeah, so that depends on the phase in which you, of course, see the patient. So if the patient is a newly diagnosed patient having fever already, then it could be due to the malignancy as well. However, because you cannot really discriminate, and if it's a child with a leukemia, we would also treat the child as having a risk of a bloodstream infection as well, due to compromised immunity at the start of the diagnosis. So we would give ceftazidime anyway, because it's difficult to separate those two. Yeah, but so we would also do a blood culture, and if the blood culture would persist negative, we would stop the antibiotics after 3 days.
Yeah, yes, Prof. Kaspers.
I noted there was sort of another question in the same, and that's really important. And that is, can we administer chemotherapy if the patient has fever, right? Develops fever, still has fever. Actually, we also discussed it this morning. I really think it's important to discriminate the patients who are early in treatment, let's say during induction treatment, or children that are much later in treatment. That's an important discrimination. And I think another important discrimination is how ill is the child. But the children that are early in induction treatment, I would argue that despite fever, even despite the child being ill, you must give the chemotherapy, because it's likely that the child is ill and having fevers because of the cancer. And then the only way to get rid of that problem is to get rid of the cancer cells. And that will not go by its own. You must give chemotherapy. So I really have very strong feelings on that, especially in your settings, because I think your chances to later on catch up are not that available. So early on, I would continue chemo. And if the child is not ill at all, I would certainly give chemotherapy. But of course, you must look at the situation. If the child is in maintenance treatment of ALL and is ill and has neutropenic and has fever, then we would interrupt the maintenance chemotherapy, right? So carefully consider.
How about the CRP or procalcitonin examination?
Yeah, but it can also be high in newly diagnosed malignancy, right? So that does not discriminate.
Okay.
Only if it's if the trend is going up while treating a patient, that's strange. So that would plea for.
So how about your recommendation? We give the antibiotics, or we postpone the antibiotics when we are facing, for example, children with cancers in the early phase of treatment. And he or she develops fever.
I think we would do both. So we would give antibiotics and we would proceed with the chemotherapy.
Okay, thank you. Maybe any more questions from the participants, or any questions from the participants who are attending in this room?
I'll ask some from your interesting presentation that you give the antifungal prophylaxis for not only ALL but to the other cancer also. So what is the criteria for giving the antifungal prophylaxis what kind of diagnosis, what kind of treatment, how heavy is it that need antifungal prophylaxis?
Yeah, that's a good question because those are our chemotherapy guidelines that are that intensive that we know that it's associated with more than 10% incidence of invasive fungal disease. So if you have that high incidence, then we say the ASIL guideline says you should give prophylaxis.
What diagnosis that you have
Yeah.
experience in your center?
Yeah, so we the AML, the recurrent ALL, stem cell transplantation children, and the last one are the ALL patients who are treated in induction or delayed intensification. Some phases of our treatment protocol, we restart again giving antifungal treatment prophylaxis.
Okay, thank you.
Any more questions?
Sari.
Yeah.
From the chat box.
Would you like to
Okay.
read because I cannot read?
At initial presentation, family patient was admitted with hyperleukocytosis. Sometimes the ANC did not fulfill the diagnosis of febrile neutropenia. But as we knew the condition, namely functional neutropenia, do you use the same guideline for febrile neutropenia for such patients?
That is what we do. Yeah, so we say every new diagnosis of a leukemia is a child being functional neutropenic. So we start antibiotic treatment if there's a fever. Yeah, but it's never really proven, right?
So I think if you have myeloid leukemia, it's more likely that if there's neutrophils, that they are also affected, so that they may function less well. So then perhaps the term functional neutropenia is appropriate. And it's even more rational to give antibiotics when they have a fever. In the children with lymphoid leukemias, the problem, of course, is in the lymphocytes. And it's not so easy to imagine why neutrophils would be abnormal.
Yeah.
So if you have neutrophils, yeah, it's difficult to prove that they function abnormally. We always have debates about this during our handovers. But you know, to avoid one case of a child not having antibiotics while he or she should have had it, we give the antibiotics for a couple of days, and then we look what's happening, and often we can stop. So we do, as Dr. Sari says, we use the same guideline that Dr. Judith says. Especially for mild leukemias, it makes a lot of sense. For the other ones, I'm not sure, but we are on the safe side.
Yeah.
So basically the treatment for febrile neutropenia and fever in malignancy, especially in leukemia, is approximately similar. Whether, in this case, the patient had hyperleukocytosis.
Yeah.
Also, you will give the antibiotics according to the treatment for febrile neutropenia.
And when a child is further in treatment, so we don't say it's a functional neutropenia anymore, and the child, so it has normal functioning granulocytes, and the child is not neutropenic, but then we would not start antibiotics. If he has a fever, so we would see the child, of course, and we would evaluate if we think the child is ill or not, or septic or not. And those decisions influence, or do we have a focus for the fever? And that all influences our decision to either give antibiotics or do not give antibiotics. So only when there's fever in neutropenia, we would always start, or functional neutropenia or normal neutropenia, we would always start IV antibiotics using ceftazidime at the least. But if there's a fever not in neutropenia, that all depends on the clinical symptoms of the child, the focus of the fever, and then we have to decide whether we should treat the child as having, for example, a sepsis or not. And then we also use other antibiotics. So then the first choice would be ceftriaxone or augmentin genta that we would use. Yeah.
Do you have some tools to assess the functionality of neutrophils, particularly in patients with hyperleukocytosis?
You have the oxidative burst, but
We don't look at
no, we don't look at it. That usually takes a long time. So you're already, you use that when you have a problem with the function of the granulocytes. So that can also be inborn. But those assays take a long time, so that's no use. Yeah, and costly.
Any more questions from the participants?
Well, so for the education also, because we have nurses also join this meeting, if the patient consult to you, she is in the induction or reinduction or AML patient having a fever, so the first education that you will give to the parents is not only giving the paracetamol, but go straight to the hospital, right?
Yeah.
Because the current mindset is, oh, you're having fever, give him paracetamol to lower your temperature. It is not too appropriate yet.
No. Yeah. We would say they should directly go to the hospital, which, if it's possible, closest nearby, to be evaluated and to be able to start early IV antibiotics. Yeah.
Can I may sort of explain? So I did not bring the slide, or Dr. Judith, we may use it next time, but there are studies that have been done that if you have no neutrophils, or if they don't function, that when you get bacteria in the bloodstream, they multiply very quickly. Right? That's a problem that you will get if you don't have neutrophils. And the problem with antibiotics is it doesn't work immediately. In a way, it resembles the allopurinol. It takes a while before the bacteria go down. And that is also why this golden hour is there, because you really have to avoid too many bacteria in your bloodstream, because at a certain stage, you're done. Yeah, you have a sepsis, you get multi-organ failure, and you are more likely to die. And that is why it's really important, if you know the child is neutropenic or you suspect the child to be neutropenic, they should go to the hospital or to any facility to quickly look at the child, to quickly look at the neutrophils. And then if you are in doubt, you just give antibiotics. Otherwise, you may wait for the result of the neutrophil count. And then if it's low, you give the antibiotics. So indeed, that is very important. It's good that you asked this. Yeah.
We have one question regarding GCSF administration. In ALL child and consolidation or intensification phase of treatment and had severe neutropenia, do you give GCSF?
She's laughing because this is my sort of hobby, AML. We have been discussing it also, I think, in the plane.
Yeah.
It's one of the advantages of coming to Indonesia. You have a lot of time to read and think and write and talk. So there have been studies done on the value of GCSF in between chemotherapy for diseases such as AML. The bottom line is there's no strong indication to use it. It doesn't help you. In fact, there's evidence for the contrary in AML. There's a part of the patients that have a variant of the GCSF receptor. And in them, it seems that if you give GCSF in between chemo, you are more likely to develop a relapse. It was shown both by the NOPO Dutch-Belgium group and by the BFM AML study group. So that is only in AML and not in other diseases. But in other diseases, the mortality is not reduced by giving GCSF. So we don't think it's much value. It is costly. You have to give it either subcutaneously or IV, so it's cumbersome.
Yeah.
So we don't routinely use it.
Yeah, we do use it in the treatment protocols, but that's usually it helps you to qualify for the next chemo course, so you don't have too much of a delay, which can be important, particularly for the Ewing sarcomas that we now treat as twice weekly, and also now in study we investigate for the neuroblastoma if that would also be a better treatment. So rapidly giving high dose chemotherapy after each other and then using GCSF to be able to continue to qualify. And only seldom when we have a child that's very ill, that's likely to go well, you will lose because of an invasive fungal disease, then you just say, well, try whatever. If it helps, it helps. But yeah, there's no evidence.
Okay. Any more questions?
Can we ask questions?
Okay.
Do you or does anybody in the audience have some data on the type of infections that you have? So culture by culture, what do you have some results already? If not, are you working on it? Is it possible?
We have the data for 2 years ago, but I'm not very sure how exact it is right now. But from that data, we have the gram-negative organisms, mostly the gram-negative organisms, some of it the gram-positive, and the fungal culture that ground was the Candida albicans, if I'm not mistaken. And from that result, then we developed the guideline for febrile neutropenia on this hospital. That's why we are not giving the ceftazidime as in your center, but we give ciprofloxacin or ceftriaxone as the first line for febrile neutropenia here. That I'll show you later. The data.
Yeah.
Dr. Ari.
I think all has been explained by Dr. Sandra. Yeah, but we are not sure how many percent of our patients with febrile neutropenia were negative for cultures. But when we do the cultures, most of the cultures showed sensitive for ciprofloxacin or ceftriaxone. But we are not sure how many percent of our patients developing febrile neutropenia with positive culture.
Yeah.
Any questions? Any more questions?
Perhaps last one about the urine alkalinization in hyperleukocytosis. What do you think about it? Should we still do that, or is it
You can
only
better because
for high dose method?
it's not we don't use it anymore.
No, we did it for a long time. We did it for a long time. I was trained that you should do it, so then you do it. And actually, I was at a meeting in Kenya with colleagues from the US. And he looked at me and he said, "What are you doing? Alkalinization in acute leukemia." I said in the beginning, "We don't do that." And I thought, well, that is strange. And I asked to some colleagues in Scandinavia, and some did and some did not. And then we looked at the literature, and it turned out that there was hardly any evidence. There was a little bit of evidence from an animal model. And then talking with pharmacologists and biochemists, we concluded there's not really a good indication, especially not when you have resburicase, because then you can get rid of the uric acid quickly. So we stopped it, and we have not been punished for that. We have not seen problems. So we are not using it. I'm not totally sure whether in your setting without resburicase, meaning you will have higher uric acid levels, also because your patient's coming later. Because it's about the balance, the alkalization is about the balance between the calcium phosphate precipitation and the uric acid crystal precipitation, right? That's the balance. And with a higher pH, there's less risk of the uric acid precipitation, but when the pH is lower, it's the other way around. So it's a balance.
But I think in our patients, what percentage would we give the allopurinol and what percentage would we give the rasburicase? I think
if you have low, so we would give the rasburicase only in higher risk patients.
Yeah.
So in the low risk patients, I'm pretty sure you can omit the alkalization.
Yeah, exactly.
Yeah, that's very true. In your patients, you may not always know. You may have more high-risk patients, but we dropped it, and for us it was okay. But be careful in your setting, and especially if you do not have respiricase in the high-risk patients. With high-dose methotrexate, we still use it. Yeah, and I think there is better evidence that it is important to have the pH above 7. It's not necessary to have it between 7 and 8, because in that setting, it simply should be above 7, but it can also be 9. And but we had a long time that also with high-dose methotrexate, we were trying to keep it between 7 and 8, but that comes from the induction where there's this balance. But with high-dose methotrexate, it can be 9, the pH, no problem.
Yes.
Yeah, we have one more question. I think this is the last one from Dr. Sari in Bandung. She is asking about your experience of using micafungin.
Yeah, it's quite good. This we should ask our infectiologist, but I know that they recently looked at the incidence of invasive fungal diseases during induction for children with ALL. And they compared the data for the current children who are receiving micafungin compared to the historical cohort that received itraconazole. And they saw a better prophylaxis, so lower incidence of invasive fungal diseases in the micafungin group. So that's quite good. And that's only new data are coming because it's a recent drug and now recently used in children. But it's it's looking quite good actually. So we use it twice a week, IV with an infusion time of 2 hours. And we try to combine it with other things that need to be done for the child. So he can come into our hospital twice weekly.
Prof. Kaspers, do you have any addition regarding the use of micafungin?
No, I completely agree. This was investigated in ALL, so we are not totally sure whether that would also be true in other diseases. On the other hand, why would it be different? It's not so much the disease, it's more about the treatment and the complications from it, prolonged neutropenia.
Yeah.
That is perhaps the only sort of remark, but otherwise fully agree.
Yeah, we are now coming to the end of the session, but before we close the session, let me summarize what we have learned this afternoon. We have learned that we should pay more attention to infection as it may lead to fatalities in children with cancers, especially those who are receiving chemotherapy and other immunosuppressive drugs. And we have to educate the patients or their families to come to the nearest health centers when the patients experience fever to receive the antibiotics at the golden hours without any delays. Thank you very much for Prof. Kaspers and Dr. Judith for your kind presentations, and I will pass my microphone to Dr. Sandra.
Thank you, Dr. Bambang Ardianto. Ya, mungkin saya akan menekankan lagi kesimpulan hari ini. Seperti yang Dr. Bambang katakan, untuk infeksi pada anak kanker kita tidak bisa menjamin luarannya akan seperti apa, maka bila ada demam segera diedukasi untuk ke rumah sakit. Ya, tidak tadi seperti hanya diberikan paracetamol, tapi kita perlu cek apakah anak dalam kondisi sepsis atau tidak, dan apakah diperlukan pemberian antibiotik intravena ataupun yang oral. So that's all the wrap up for this session. Thank you very much for all your participation. Please sign up for the presence list, and then the files for today will be given to you all in the end of this meeting. Thank you. We'll see you again in the next year or perhaps next few months lecture. We hope that this seminar will give good insights on you and all of our patients. Thank you. Have a good day.
Thank you.